Let's move on to the ever important clinical manifestations of Turner syndrome, which is very important. Lots are there, but it's worth understanding all this. So clinical manifestation wise, the most important manifestation will be on the growth. Very important manifestation. Almost 100% of all Turner syndrome individuals will have this growth related issues. Remember, very rarely certain mosaic individuals may achieve a normal height where there is very less dose of this Turner's karyotype in their body. But apart from that, almost all will have this growth related issues. So short stature is one of the main important things. Short stature is mostly due to the SHOX gene involvement. But let us see what are the problems in this Turner's patients. Number one, Turner syndrome patients, they will be short at birth itself. They are slightly short, not very short compared to the age matched controls. So they are slightly short at birth itself, and they'll have a reduced growth velocity during their childhood period, which can be plotted in the growth chart. But this is a very important thing. So do not plot this growth velocity in the usual growth chart. You have to use the Turner's chart. There is separately Turner's chart for these individuals. You have to plot it with that only. Then only you will be seeing the differences. If you put it in a routine growth chart, you might miss some vital information. Always plot in the Turner's chart, which is available separately. And they will be having a reduced pubertal growth spurt as well. They will not have a good pubertal growth spurt. They will have a reduced pubertal growth spurt, and overall, they are going to be 20 centimeters short compared to the age matched controls. Clear? This is the destiny of Turner syndrome patients. And how we can avoid this. But before that, you have to understand what are the things that stimulate the epiphysis to grow and which produces vertical length of the bones. First is the growth hormone through IGF mechanism. We know that already. This is a very simple thing. Second is the estrogens, especially the estradiol play a very, very important role. And you might ask me in a pubertal life, what is the role of estrogen during growth? No, it's not that case. Now the modern researchers have come very clearly that estradiol is very important in the prepubertal life itself. Even though it's not significantly high in the prepubertal life, like after as in the reproductive age group, but still you have to be clearly sure about one fact that these females have 3 times more estradiol compared to the males, even in the prepubertal life, which means the estradiol has a role to play. That's why it is a little bit higher in the females, even in the prepubertal age group. So next is the SHOX gene. So the reason for short stature in Turner syndrome is thought to be mainly due to loss of the SHOX gene in the pseudoautosomal region 1 in the P arm. But apart from that, these Turner syndrome patients also have this ovarian dysfunction. Because of that, they will be having lower estradiol, and this is also thought to play a role in patients with Turner syndrome to have a short stature. So that is the idea of treating Turner syndrome in the first place. But you also have to be very sure of the fact that growth hormone and IGF-1 levels in Turner syndrome are completely normal. There is no problem in that. So you cannot do anything with the SHOX gene because it's gone already. So you have to do something with the estradiol, and you have to do something with the growth hormone. Remember, treatment wise, you can do this low dose estradiol. Ultra low dose estradiol has been formulated as treatment in patients with short stature and Turner syndrome. But this is something unjustified according to me and according to many endocrinologists, because this, even if it's low dose estradiol, you're unnecessarily exposing the girl to long-term risk of endometrial cancer and breast cancer. So we don't want to do that. And at the same time, it might, if dose is slightly goes beyond what you intend, it might result in epiphyseal fusion, and it might further worsen the short stature issue. So low dose estradiol is experimental. It is done in some countries, but right now there is no enough evidences to justify the use of low dose estradiol in this Turner syndrome patients as a treatment option. But this growth hormone therapy is one of the very, very, very important treatment options for Turner syndrome patients related short stature. Even though growth hormone is not deficient here, but like we are trying to balance it out because of the loss of this SHOX gene and estrogen, and we cannot give estrogen in most of the girls. We are trying to lift this by giving extra dose of growth hormone so that the growth becomes better. That's the rationale of giving growth hormone in these patients. And apart from that, these patients may have a lot of skeletal disturbances. What are the skeletal disturbances that you encounter? These patients may have brachymetacarpia, especially the 3rd and 4th metacarpals may be short. You might encounter this in pseudohypoparathyroidism patients also, where they might be having Albright's hereditary osteodystrophy. So brachymetacarpia, and they have high palatal arch. That's what we call it as a high arched palate. and they'll have a characteristic turnus facies. So what do you mean by characteristic turnus facies? They might be having drooping of the eyelids, that is otherwise referred to as ptosis, and they might have low setias, which have separate definitions for low setias. Remember, when you draw a line from the outer canthus of the eyeball, and that line should touch the root of the ear. So if it's not touching the root of the ear like this, if the ears are lower than this, then we call it as a low setias. They can have increased internipple distance. So you take the ratio of the nipple distance versus the chest circumference. So if the internipple distance is more than 25% of the chest circumference, we call it as increased internipple distance. And they can have a wide carrying angle. This is quite common in Turner syndrome people. Usually girls itself tend to have a wide carrying angle, but this Turner syndrome will have an even more wider carrying angle. And this is due to the fact that this Turner syndrome patients will have a reduced vertical length, but they will have an increased horizontal diameter. So increased horizontal diameter, and the AP diameter also will be a little bit increased in this patient. So that is because you can imagine like this, when you become short like this, they will expand a little bit in the transverse diameter, horizontal diameter. So that is, and AP diameter also may be increased in these individuals. And these patients inherently have increased fall risk as well. Apart from these problems, they have increased fall risk because they are inherently a bit unstable, even though they don't have any cerebellar issues, but their movement coordination may not be that good compared to that of the normal age matched control. So they have increased fall risk. And they do tend to have increased bone resorption due to a variety of issues, and this can result in osteoporosis. Coupled with increased fall risk and coupled with the fact that they have osteoporosis, they are at increased risk of fractures at a very younger age itself. But you have to be absolutely sure about one thing, but there is no role for bisphosphonates because it is not a problem of osteoclast, it is not a problem of osteoblast. So giving a bisphosphonate has no role in Turner syndrome. This is a very, very important point. No role for bisphosphonates. Let us see some of the images. So this is the brachymetacarpia I'm talking about. So you can see here the metacarpal length is short, and this is what we refer to as a brachymetacarpia. And this is an example of a Madelung deformity which happens due to problems in the SHOX gene. What do you mean by Madelung deformity? So this is a normal wrist on the right side. You can see the wrist on the left side is abnormal, where you can see the ulnar third of the radial bone. This is called the ulnar third of the radial bone. This area is having defective development due to problems in the epiphyseal development. Defective development. Because of that, it will be underdeveloped, and because of the same, you can see the distance between the two bones, that is ulna and radius, will be increased. But here the distance you can see is very much short, but here the distance is increased. Clear? And at the same time, there will be a dorsal subluxation of the distal radio-ulnar joint. So this is very, very important. So you can see the dorsal movement of this distal radio-ulnar joint, and the ulna may protrude a little bit dorsally. So this is what we refer to as a Madelung deformity. It is due to defective development of the ulnar third of the epiphysis of the radial bone. Clear? Fine. So this is one of the important phenomenon. This I'm going to describe later on along with the lymphedema. This is what we refer to as a webbing of the neck, webbed neck appearance. And remember, this webbed neck is very, very important. The reason because this webbed neck will tell you this is an external marker of an internal cardiac disease, which means if the patient is having a webbing of the neck, there is increased risk of having cardiac anomalies. Remember, cardiac anomalies happen in only 45% of the Turner syndrome patients, but whenever they have webbed neck, the incidence will be very high. So increased risk of cardiac anomalies. And one more thing that correlates with increased risk of cardiac anomalies is the fact that if they have increased AP diameter, they have increased transverse diameter, all right, but if they have increased AP diameter, that is also a risk factor for developing cardiac anomalies in these individuals. So there's an external marker. And this image will show you the wide carrying angle and other skeletal abnormalities like increased internipple distance and they're having a shield-like chest. And that's one of the important problems with Turner syndrome, important external marker of Turner syndrome. And they're also having the webbing of the neck. And it's not shown very clearly, but this child is having this drooping of the eyelids also, ptosis as well. So it's a characteristic Turner feature, characteristic Turner face. So these are some of the skeletal problems that you encounter with Turner syndrome patients. Then what are the ovarian issues? Many of these patients will have ovarian dysfunction. Almost 90 to 95% of the patients with Turner syndrome will have ovarian dysfunction. Ovarian dysfunction in Turner syndrome is due to multitude of causes. The most important cause being increased rates of follicular atresia. Remember, this follicular atresia and loss of follicles is a common phenomenon in any girl's life. For example, the number of follicles you see at birth is not the same as number of follicles you see at puberty, which will be much lesser. And the number of follicles you see at puberty is not the same as number of follicles you're going to see at menopause, which is going to be even more lesser. So this loss of follicles and atresia of follicles is a normal phenomenon in any girl. But this Turner syndrome patients will have increased follicular atresia, which means their follicular loss will be so much higher that they lose almost entire follicles even before they reach puberty. So probably this is one of the reasons why Turner syndrome is considered as a cause of a very, very early premature ovarian failure or ovarian insufficiency, and that's the reason why they tend to have a very high FSH. Fine. Coupled with that, it's also a condition which produces this gonadal dysgenesis. It's not a true gonadal dysgenesis. It's not that extreme, but still it can produce a type of gonadal dysgenesis called streak gonad. So it's a combination of dysgenetic gonads as well as loss of this follicles. Both of this accelerated loss of follicles and presence of streak gonads is linked to these two genes, that is BMP15 and this TIMP1 and 2. So which are supposed to stabilize the ovaries and stabilize these follicles. The loss of this in the pseudoautosomal regions might result in accelerated loss of these follicles. But remember, in general, this Turner syndrome patients will have extremely low estrogen because of low follicles and premature loss of these follicles and ovarian insufficiency. Because of that, they'll have extremely high levels of FSH. This low estrogen is also the reason why they have primary amenorrhea. They cannot develop menstrual cycles. And this low estrogen is also the reason why they do not develop breast. There will be no breast development, no secondary sexual characters. But remember, there are some variations also. There are, in fact, considerable variations are there with regards to Turner syndrome. Remember, some patients may have very accelerated loss of follicles. Some patients have a little bit slow loss of follicles. Based on how fast they lose the follicles, the clinical picture might be a bit variable. For example, almost 80 to 85% will follow the classic picture which I told you. But there are 15% of the individuals who may have some breast development. Some breast mount elevation may be there, which means there is some follicles which are still left during puberty, which might produce some estrogen resulting in some breast development. Some breast mount elevation is seen in some patients, like maybe at least a tan at 2 or 3 might be there. And almost 6% of the individuals even may attain menarche, and less than 1%. But still, some sizable number may even get pregnant, but very rare in general. In general, in exams, you have to think about this only. Primary amenorrhea, infertility, no breast development, very high FSH. This is classic Turner because of the loss of follicles, and at the same time, ovaries will be dysgenic and they will be having only streak gonads. And number 3, the ever important cardiac issues with Turner's happens in approximately 45% of the individuals with Turner syndrome. And if they ask you the most common cardiac problem with Turner's, that is elongated transverse aortic arch, which happens in approximately 40 to 60% of the Turner syndrome individuals. Elongated transverse aortic arch, which happens in 40 to 60% of the Turner's individuals. Second most common is the bicuspid aortic valve, which can happen in 30 to 40% of the individuals. And third one is the coarctation of aorta. Remember, this is what together we call it as the famous aortopathy. Majority of the Turner's problems will be left-sided problems, not right-sided problems. This is what we refer to as aortopathies. And these aortopathies poses these patients at extremely high risk for aortic dissection. So remember, this is one of the important cause of death in patients with Turner syndrome. So Turner syndrome patients have 100 times increased risk of developing aortic dissection, and they develop at a younger age compared to age-matched controls. Like at 35 years itself, they will develop aortic dissection most of the time. And that is the reason why you have to monitor with echocardiogram. And again, how frequently you monitor depends on the initial assessment with aortic size index. So why I'm going to call it as aortic size index is the fact that this aortic size cannot be considered along with other adult population or childhood population, because these children will be very short and these adults will be very short, and you have to adjust this aortic size based on the height as well as the age. So if the aortic size is more than 2 centimeter per meter square, it's a definite worrying sign. It's a sign of concern. If it's more than 2.5 centimeter per meter square, it's definitely a very, very worrisome sign, and it's a risk. And the medical therapy you can give with ACE inhibitors and beta blockers to reduce the progression of this aortic root dilatation. So anyways, what are the other cardiac issues these people might develop? They can develop something called a hypoplastic left heart syndrome, rare, but still again another left-sided problem, and they can develop a pulmonary venous defect as well. They can develop this pulmonary venous anomalies and pulmonary venous defects also. Fine. ECG wise, these patients tend to have a short PR interval, long QT relatively, and that's why certain drugs with long QT has to be used carefully in these individuals, and they might have a right axis deviation. So these are some of the ECG findings that are related to Turner syndrome. And fourth one is the lymphedema, and strikingly this lymphedema is extremely common at birth only. More than as the child grows, this lymphedema slowly tends to disappear, and this lymphedema is thought to be the reason for this webbing of the neck. Remember, webbing of the neck is related to more incidence of cardiovascular abnormalities, and this lymphedema is thought to be the reason for the shield chest they have an abnormal development, and this lymphedema is thought to be the reason for the renal defects that this patient encounter. There are a variety of renal defects that this patient might encounter, like horseshoe kidney, pelvic kidney, unilateral renal agenesis. A lot of renal defects these patients might encounter, and this lymphedema is thought to be the reason for the development of these nail defects that are associated with this Turner syndrome patients as well. So lymphedema is a very important thing to be known. And then we have ophthalmologic involvement, eye involvement, where these patients may develop myopia and hypermetropia. Myopia, even though is quite common compared to that of hypermetropia, and you can get a color vision loss in approximately 8% of the individuals, and they can even go for amblyopia. So structural problems, these are functional eye issues, and structural eye issues like squint or strabismus, presence of epicanthal folds, which is a cosmetic concern, and patients may have ptosis and drooping of the eyelids, which I have told you already. So clearly, these are some of the structural problems that this Turner syndrome patients might have, and it might need correction sometimes because of the cosmetic problems. And what are the complications? Because of all these problems, what are the complications that this Turner syndrome patients might encounter? They may go for keratoconus, which is fairly common. They can go for glaucomas and cataracts, expected with myopia, hypermetropia, and retinal detachment. Expected with myopia and hypermetropia, retinal detachment. So these are some of the complications that these patients might go because of the eye involvement. And they can have this hearing involvement or ear involvement. Remember, most of the times to start with, this Turner syndrome patients will have conductive hearing loss only. Conductive hearing loss, initially at least. To start with, they have conductive hearing loss, and this conductive hearing loss is thought to be due to palatal defects. Why palatal defects? These palatal defects increase the risk of ear infections. That's why transmission of ear infections. So probably these palatal defects are the reasons for initial conductive hearing loss that these patients encounter, and majority of the patients will have this sensory neural hearing loss within 40 years of age. And usually they lose the hearing in the mid-frequency range, in the 1000 to 2000 Hertz range, and usually it is due to cochlear defect that these patients have. Clear? And these patients are also at increased risk of development of cholesteatoma, which might require surgery. Cholesteatoma, increased risk of development of complications like cholesteatoma. which might necessitate surgery. Remember, this hearing problems with regards to Turner syndrome, there is one interesting association in the genetics. We don't know why, but these hearing problems are more with patients who are having classic Turners, that is 45XO karyotype, and patients who are having isochromosome XQ. I told you the genetics already. In patients with isochromosome XQ type Turner and classic Turner might have this increased frequency of this hearing loss. Remember, classic Turner is only 45%. Astonishingly, it's not common. 45% only will be having classic Turners. Remaining lot of variants, mosaic Turners. Then you might have this isochromosome XQ, ring chromosome formation. Fine. So multiple types. So then you can have this gastrointestinal tract abnormalities. So they can go for GI bleeding. And this GI bleeding is because these patients have increased risk of developing this hemangiomas in the GIT and telangiectasias in the GIT. And these patients may develop malabsorption. And this malabsorption is due to these patients having increased risk of developing celiac disease and inflammatory bowel disease. And they can have some hepatic issues also, where the patient tend to have elevated liver enzymes like ALT and gamma-glutamyl transferase. And these patients also tend to have a variety of neuropsychiatric issues. But in general, in exams, if they ask you, you should be very clear that these patients tend to have a normal intelligence. That is very important. So whenever they ask you an exam, you should always answer these patients tend to have a normal intelligence, with only one exception of the ring chromosome type. This ring chromosome, because of this cyst inactivation, cyst dysfunction, you might result in this mental retardation, syndactyly. We have discussed that already. But apart from this one exception, Turner syndrome patients generally are supposed to have normal intelligence. Very important point. But even though the overall intelligence is supposed to be normal, they do suffer from certain cognitive disabilities. Like for example, they might be having problems with visuospatial skills, which causes significant issues in certain social activities like driving. So they have reduced problems with this visuospatial skills. And this is the reason why they fall often also, as I've told you previously, and they're prone for fractures. And they have reduced response to social cues. They have some problems too in responding to various social cues as well. And they have some problems with non-verbal communication. And they have some problems with mathematical skills, and they suffer a lot in calculations, mathematics. And interestingly, this visuospatial skills that are defective is associated with this paternal X chromosome. Whenever I told you in the beginning, it's 70% this X comes from maternal side and 30% comes from paternal side. Whenever they have these problems with this visuospatial skills, it's very likely that the patient has inherited this X chromosome, that single X chromosome that is normal, that is from the paternal side. And this reduced response to social cues and this non-verbal communication problem is usually related to inheritance of this X from the maternal side. So which means if the single X that is normal is inherited from the maternal side, they tend to have a problems in the social responding to the social cues and problems in non-verbal communication. Clear? Apart from that, these individuals can have variety of autoimmune disorders, prone for variety of autoimmune disorders. For example, as I told initially, they are prone for autoimmune thyroiditis, and they are even prone for the celiac disease and inflammatory bowel disease, IBD. Previously, it was thought that these individuals are prone for rheumatoid arthritis. Right now, it's been clear that these individuals are not prone for rheumatoid arthritis anymore. And apart from that, there are some other issues that these patients generally suffer from. It could be diabetes mellitus type 1 or type 2, and second is adiposity, which is clearly very, very important. And generally, this adiposity tends to be of male pattern of adiposity, which is predominantly abdominal obesity or abdominal adiposity. And remember, this development of this male pattern adiposity is related to inheritance of this X chromosome from the maternal side. Usually, if the Turner syndrome patient has inherited this maternal X chromosome as the normal chromosome, then probably these patients might develop this adiposity, which is of male pattern adiposity. So some interesting things are going on. Fine. So these are some of the important features of Turner's. And now let us move on to the diagnostic criteria for Turner's. How we are going to diagnose a Turner's. We have very strict criteria with regards to diagnosis of Turner's. The first criteria is the patient should be phenotypic female. It's a very strict criteria, which means by default a male or anyone who's having ambiguous genitalia, you cannot take them as diagnosis of Turner syndrome, not possible. And second, you should have clinical criteria, some clinical features should match with Turner's, and clinically speaking, you should have at least one major criteria. Yeah, major as well as minor, you should have at least one major criteria, and along with that, you should have at least two minor criteria to diagnose these individuals as Turner's. What are the major criteria? They should have the characteristic face, or they should have this cystic hygroma, which can be diagnosed even prenatally in the ultrasound, during antenatal ultrasound, or it can be diagnosed at birth, or the child may have a cardiac problem, the classic iridopaths, or growth-related issues like short stature, or ovarian dysfunction, which is highly premature and they have a streak gonads. And these are some of the major criteria for diagnosing Turner's. And minor criteria include renal abnormalities, which I told you, horseshoe kidneys, pelvic kidneys, unilateral renal agenesis, skeletal defects like this brachymetacarpia, and this maid-lung deformity, and a lot of nail changes or presence of hearing loss, which happens within 40 years of age. So these are some of the minor criteria. You have one major, at least two minor. It's a clinical criteria for diagnosing Turner's. Along with this clinical and phenotypic female as a criteria, you should have evidence in the form of karyotyping as well. Remember, karyotyping is considered to be the gold standard for diagnosis of any chromosomal disorder, including Turner's. So, karyotyping, how will you be doing karyotyping? Remember, you should take the sample first for karyotyping. What are the samples that are preferred? The most important sample is the blood, where they will be taking this lymphocytes as the cells for karyotyping. And second, you can prefer other samples also, like fibroblasts of the skin fibroblasts. Then you can prefer this buccal mucosal cells. Even some studies show urine as one of the good specimen for karyotyping. But these are done only if needed. Generally, we do in the blood, taking the lymphocytes. And minimum, you should examine at least 30 metaphase chromosomes. That is the least minimum. This is the criteria actually. At least 30 metaphase chromosomes should be karyotyped and examined. Metaphase chromosomes must be examined. Clear? This is the minimum criteria. And in the karyotype, what is the finding you have to see? At least the one X chromosome should be completely normal. This is most important criteria. And another X chromosome should be defective, which means either it could be a partial loss of this X chromosome, or either it could be a complete loss of this X chromosome. And one criteria has been laid recently. There is something called XP24. Usually deletions beyond this XQ24. XQ24 is a region in the Q band. So in the Q arm, you have multiple regions, isn't it, and bands. So if it's beyond this distally, if the deletions are happening beyond this XQ24 region, it should not be called as Turner syndrome. Isolated deletions of this Q arm of the X chromosome beyond this XQ24 area is not Turner's. Even though they will result in isolated ovarian insufficiency, they will have isolated ovarian dysfunction, these individuals who are having deletions beyond XQ24, but this should not be called as Turner syndrome. They just result in ovarian dysfunction due to XQ24 deletion. It's not Turner's. That's the most important point. Fine. So this is the karyotypic definition of diagnosing a Turner syndrome. Fine. So you can also make this antenatal diagnosis of Turner's. So how are you going to make antenatal diagnosis? Antenatal diagnosis of Turner's. Antenatal diagnosis of Turner's is quite simple. So you can identify this nuchal translucency, which is suggestive of a cystic hygroma, or you can find out the actual cystic hygroma itself. You can find out the renal anomalies that are associated with Turner's, and you can also find out this short femur. Clear? These are some of the findings in the antenatal ultrasound that will probably alert you towards diagnosis of a Turner syndrome. But please do remember, whenever you have doubts regarding Turner syndrome, the next step is always doing an amniocentesis or a chorionic villus sampling and then doing a karyotype. This is the best thing. So remember, for Turner syndrome, there are no markers, blood markers, like what you study in Down syndrome, this triple assays, quadruple testing, nothing is there for Turner's. So there is no blood markers that are suggestive of Turner's or diagnostic of Turner's. Not possible. Fine. So now we are moving on to the treatment of Turner's. Treatment, there are a lot of modalities of treatment. There are three things which you have to consider. The first one is the cardiac. And the second one is the pubertal induction. And the third one is the growth. So there are three things which you have to consider as far as Turner syndrome is concerned. So first one is the growth. Second one is the pubertal induction. And third one is the cardiac problem, which has to be taken care. And cardiac and probably other issues. Other issues are not that important. So even though it has to be taken care, but cardiac is very important. So how you are going to take care of the growth? Because these patients are prone for short stature and they won't reach the final height unless until you treat them. So the usual preferred agent is the growth hormone, even though ultra low dose estradiol has been studied, but right now it's not justifiable by which I already described. But growth hormone is one of the important therapies in Turner syndrome to at least improve their height. So what is the dose of growth hormone? Usually we give 40 microgram per kilogram per day, or you can give a maximum dose of 68 microgram per kilogram per day. You should not exceed beyond this dose. Usual dose that is started in Turner syndrome is 45 microgram per kilogram per day. At the same time, you can stop this growth hormone therapy once the bone age is more than 14 years. This is a very important criteria. Once the bone age exceeds 14 years, you can stop the growth hormone therapy. And obviously, once the bone age reaches more than 14 years, your vertical growth velocity will be less than 2.5 centimeter per year. Once you see all these criteria, you can stop the growth hormone therapy. The expected improvement in height every year and the expected benefit in height that is expected to achieve in a Turner syndrome patient with growth hormone therapy is at least 1 centimeter per year. So that's the improvement compared to the other individuals that you will be getting with growth hormone therapy. Clear? Fine. So which means what I'm trying to tell is when you compare with other individuals with Turner's who are growing at a particular height, and when you use growth hormone therapy, when you compare patients who are not receiving growth hormone therapy, when you are comparing the patients who are receiving growth hormone therapy, both are Turner's, and these patients who are receiving growth hormone therapy will have that extra 1 centimeter per year benefit in the height. So that's the expected benefit with growth hormone therapy. And growth hormone therapy is not without side effects. It's going to have a lot of side effects as well, like idiopathic intracranial hypertension and headache possible. They can develop this slipped capital femoral epiphysis, especially in children. It's quite common. Scoliosis possible, and this increased risk of nevus and skin pigmentation. Remember, Turner syndrome patients are naturally at risk of developing this blue nevus and skin pigmentation. This growth hormone therapy worsens that. It can produce new skin nevus and pigmentation, and it can unmask hypothyroidism by a multiple mechanisms and variety of mechanisms. It can unmask the underlying hypothyroidism, maybe primary or secondary. And remember, this Turner syndrome patients, autoimmune thyroiditis means they are inherently prone to have high levels of anti-TPO antibodies. Whether that translates into clinical hypothyroidism or not is a question, but still they naturally tend to have high levels of anti-TPO antibodies, and growth hormone therapy might unmask your primary or secondary hypothyroidism, which is already present in these individuals. And when you will start the growth hormone is generally started best at around 2 to 5 years of age. That's the best time to start. Or if you have missed the bus, you can start by around 10 to 11 years of age, at least 3 years before the expected puberty onset. So that is the best time to start the growth hormone. It's better to start around 2 to 5 years of age itself. You prevent that growth failure rather than treating the growth failure after missing the bus. So pubertal induction is very important in terms of this girls identifying themselves of girls to produce breast development and to cause this growth and epiphyseal fusion. This pubertal induction is really important. So pubertal induction is usually done with estrogens, and when you start this estrogens, you can start at either 11 to 12 years of age or at 14 years of age. So why this different school of thoughts? 11 to 12 years of age, if the patient has already achieved the desired height with growth hormone therapy, if the patient has not achieved the desired height with growth hormone therapy, or the patient has not used the growth hormone therapy, then you can give a cushion of extra 3 years. You can wait for this 14 years to give that extra height, because estrogen is something at a higher dose which you're going to give at a dose to start pubertal induction that might actually fuse the epiphyse. Estrogen is one of the important reasons for epiphyseal fusion. At low dose, it can produce a little bit of growth, but higher doses that are happening at puberty, it might cause actually epiphyseal fusion. So that's why you give that extra cushion in girls who have not achieved the desired height, and you can start at 14 years of age. And what are the preparations that are available as far as this estrogen is concerned? You have ethinyl estradiol, which is given orally. You have estradiol valerate, which is again given orally. And you're going to have conjugated estrogens, which are again given orally. And you have this transdermal estrogens. If they ask you the choice of estrogen in these girls with Turner syndrome or any long-term estrogen, the best option is always the transdermal estrogen. There is no doubt about that. I'll tell you why this is preferred. But if that is not available, then you can go for this estradiol valerate. This is very commonly preferred in these girls, especially in younger population. Ethyl estradiol is too strong to be preferred, and conjugated estrogens are not very common. So what is the reason, purpose of giving this estrogen? Purpose of giving this estrogen mainly for the breast and the uterine development. Breast and the uterine growth, you need this estrogen. Without estrogen, your uterine growth also will not happen, and your Mullerian structures will be rudimentary. Without estrogen, they will not grow. And these girls can potentially achieve fertility if they are having good number of oocytes later on in life, where oocyte transfer and modern assisted reproductive techniques can make them fertile if they have a good Mullerian growth. So for Mullerian growth, and especially for uterine growth, which is a Mullerian structure, and for breast development, you need this estrogens. So that is the reason why we give estrogens. And what are the benefits, extra benefits that you're going to get apart from this breast and uterine growth if you start with estrogens? So one is you're going to get this bone health will be very good, because without estrogens, they go for osteoporosis and they'll have high risk of fracture. So for bone health, it is very good. And for neuropsychiatric issues, it is very good, which means it improves these neuropsychiatric problems, that cognitive issues that we have discussed some time back. And for liver-related issues, estrogen provides benefit. It reduces the ALT and gamma-GGT enzymes. And for growth, it is reasonably helpful, especially at lower doses, not higher doses. Higher doses, it will fuse. Lower doses, it might help. And it helps in reducing the aortic stiffness. It helps in reducing the aortic stiffness and reducing the risk of dissection and coarctation. And it's also going to reduce the adiposity. This adiposity is going to benefit from estrogen. Remember, these are the additional benefits that you get apart from the breast and uterine growth with regards to estrogen use. Why we prefer transdermal estrogen? There are multiple reasons. So whenever you give oral estrogen, we know very well it has to be absorbed first in the GIT. You give this oral estrogen and it has to be absorbed, and it undergoes a significant first-pass metabolism. First-pass metabolism, and which means the effective bioavailability will be very less. So the bioavailability is very less, and the dose you needed to give must be very high, and you cannot pinpointly alter the dosage as well. So that's why this is one problem. Problem number one, reduced bioavailability due to extensive first-pass metabolism. And during the first-pass metabolism, this estrogen can interact with a variety of substances in the liver. Lot of substances in the liver. What are the substances? For example, it can reduce the IGF-1 levels. Estrogen is known to reduce IGF-1 So which means it can adversely affect the growth, and it can reduce the protein C. So once it reduces the protein C, it increases the risk of thrombosis, because this oral estrogen has more interaction during passage through the liver with this protein C production. So it can produce thrombosis, and that is the reason oral contraceptive pills are associated with more risk of thrombosis, and oral hormone replacement therapies are associated with more risk of thrombosis compared to the transdermal estrogens. Very important point. And they are going to produce reduced activity of this lipase, which might result in dyslipidemias, and they can increase the levels of angiotensin 2, which means it can accelerate the conversion from angiotensin 1 to angiotensin 2, resulting in hypertension, or reduced destruction of angiotensin 2, resulting in hypertension. So these are some of the problems that are associated with oral estrogens. So reduced bioavailability, at the same time you are having a whole lot of problems as well with oral estrogen. So that is the reason why you wanted to give a transdermal estrogen as a choice, because these girls need longer term estrogen use, and you have to choose very carefully. So which is having lower side effects, and use as little as possible, which is important for their physiological functions. That is more than enough. So you're going to treat the pubertal induction by this way. Remember, progesterones are not generally started initially. Progesterones you can start usually after 2 years of breast development. So once the breast development happens, which is usually going to happen by 2 years after starting estrogens. So after 2 years, you can start progesterone, or you can start after adequate breast development, because progesterone is going to adversely affect the breast development. That is very important. Clear? So overall, you are trying to make them females, because without this estrogens, they will have breast atrophy, their Mullerian structures will not grow, they will not become fertile, they cannot do any surrogacy. Even if they do oocyte transfer, they cannot bear the child. So it's a problem. And whether these people can go for pregnancy or not, yes, actually they can go for pregnancy. Actually they can go for pregnancy, provided if they have a good oocyte number at the time of diagnosis, so that they can go for this OOPEC-C, oocyte donation at a very younger age itself. When they have a good amount of follicle itself, if that time itself they give this oocyte, there is a good chance that these patients might become pregnant. Or even cryopreservation have been suggested. Cryopreservation of this ovaries has been suggested, but these are long shots in developing countries like India, but still it can be done, especially if you are going to advanced centers. At the same time, there are some contraindications to pregnancy, especially if the patient is having this ierotopathies. This presence of this ierotopathies, this hypoplastic left heart syndrome, are contraindications to pregnancy. You cannot do, especially when the patient is having coactation. Pregnancy itself is a high risk of dissection, especially third trimester of pregnancy is going to carry extremely high risk of dissection. So in the presence of coactation, or probably in the presence of a bicuspid aortic valve, it's risky to go for pregnancy. If they don't have, then yes, you can obviously take the patient for pregnancy itself. So cardiac and other problems, generally you do conservative, and you need frequent monitoring, especially for that aortic size index. Frequent monitoring with echo is mandatory with aortic size index, and usually we give it in the terms of standard deviation rather than giving absolute centimeter per meter square. Even you can give it in terms of standard deviation. If it's less than 2.5 standard deviation, generally they won't have any restriction. If it is more than 2.5 to 3 standard deviations, more than what compared to the age-matched controls, you have to restrict your activities. If it's 3 to 4 standard deviations, then you can start with some ACE inhibitors and beta blockers. If it's more than 4 standard deviations away from the general population of their age-matched controls, then you have to even counsel them for surgery. Clear? It's a high risk. So again, how frequently you should monitor echo, and that's beyond the scope of the current discussion. So that will not be asked, and that's guideline based completely. So let us stop with this. And finally, before finishing off the topic, let me tell the difference between two important disorders. One is the Turner syndrome, and second is the Noonan syndrome. People will expect me to tell difference between Turner syndrome and Klinefelter syndrome. No, I won't, because Klinefelter syndrome are males with mental retardation, Turner syndrome are females with good intelligence. There is nothing to differentiate between them. Clear? But this Noonan syndrome often needs this differentiation, because Noonan syndrome is once upon a time, and in fact erroneously by many people, still call that as pseudo-Turners or a male Turners. So why it is called as a male turnus and why it is called as a pseudo turnus, and what is the reason for that? So remember, first of all, there is a universal gap between this turnus and nunans. Both are not the same at all. The only thing that is common between the two is the stigmata that you see. There are some stigmata that can be common. For example, the ptosis, the webbing of the neck, the shielded chest is common in both these two conditions. So that is the only thing. The stigmata may be seen in both these two conditions, and that is the reason why many of the old professors tend to call this as pseudo turnus, this Noonan syndrome, or a male turnus. So first, what is the sex? Sex of the individual turnus is always a female. I told you this multiple times, whereas Noonan syndrome can be a male or a female. So that is the reason why females with Noonan syndrome are called as pseudo turnus, and males with Noonans are called as male turnus. But anyway, it can happen in both males and females. Why is that so? Because remember, what is the inheritance? So it is not inherited in the first place. Turner syndrome is a chromosomal issue. It is not inherited. None of the chromosomal issues are inherited. Clear? Absolutely. None of the chromosomal issues are inherited in the first place. And Turner syndrome has a risk with increased paternal age. Remember, your Down syndrome is associated with increased maternal age, but whereas Turner syndrome is associated with increased paternal age. It's been proven. At the same time, Noonan syndrome is not chromosomal disorder. It is an autosomal dominant Mendelian inheritance. Chromosomal disorders are not inherited. First of all, you have to be very clear. It's not Mendelian inheritance. It's not inherited. It happens just like that due to mutations during the time of fertilization and zygote formation. So, but this Noonan syndrome is an autosomal dominant condition due to Mendelian inheritance. Many different types of Noonan syndrome has been postulated, but almost 70% of the cases will be having this type 1 Noonan syndrome, which is due to this PTPN11 mutations. And many things act through this tyrosine kinase, like epidermal growth factor. A lot of pathophysiologists are there along with it. But anyways, this PTPN11 mutation is the reason for developing this Noonan syndrome in almost 70% of the cases, especially the type 1 Noonan syndrome, which is going to be the most common. And apart from that, you have differences in the cardiac issues also. Remember, Turner syndrome patients will have more of a left-sided problems and mostly aortopathies. That's what these patients will have. Whereas this Noonan syndrome patients predominantly will have right-sided problems. Like one of the classic problems that associated with Noonan syndrome is the primary pulmonic stenosis. Very, very important. Whenever in a practical exam, you discuss about a primary pulmonic stenosis, if you tell a congenital cause of Noonan syndrome, they'll be very happy. It's a very important cause. Apart from that, Noonan syndrome can cause HOCM. Noonan syndrome can cause septal defects. Many other defects are associated with Noonan syndrome as well. And what about the gonads? Remember, gonads are always ovaries. There is no doubt about that. Gonads are almost always ovaries, without a doubt, because these are females only. And it will be streak gonads. Streak ovaries. It's a combination of premature and very premature ovarian insufficiency along with dysgenic gonads. Whereas these Noonan syndrome patients may have either an ovary or a testis, because it's a Mendelian inheritance, autosomal dominant, where the patient can have any karyotype. It's just a Mendelian inheritance. It's a different gene altogether. It's not something related to chromosome. So they can have an ovary or they can have a testis, but they'll be normal. They won't have any problem. Which means they produce normal amount of sex hormones. That's the idea. But even though they might have, many of the Noonan syndrome patients are supposed to have cryptorchidism, that is undescended testis. But by function wise, they'll be normal. And what about the intelligence? As I told you, Turner syndrome patients will have a normal intelligence except a very rare form of ring chromosome associated Turner syndrome. But whereas Noonan syndrome patients are likely to be mentally retarded. Clear? So these are the major differences between Turner syndrome and Noonan syndrome. You can very clearly see that Turner syndrome and Noonan syndrome are completely different. And the only thing that is slightly common between these two is the stigmata that you see, like webbing of the neck and other stigmata that is seen with Turner syndrome can be seen in patients with Noonan syndrome. Clear? So with this, I will complete this long journey of primary amenorrhea and Turner syndrome. Turner syndrome is something very, very important for every single medico to know this disease and identify disease and to enjoy this disease, especially the genetic aspect, which is very cool. And I hope you enjoyed the session, and we'll move on to the next section on secondary amenorrhea and hyperandrogenism.